This is Chapter 4, Communication and Physical Assessment of the Child and Family. So when you're communicating with parents, be sure you introduce yourself, just like you're used to. Ask who they are, because there are some moms who look like grandmas and some grandmas who look like their moms. So figure out who people are, but ask in a way that is, open-ended and lets them answer. And then ask how they'd like to be addressed. I think we have a bad habit of calling people mom and dad, and they may not like that at all. So ensure privacy and confidentiality as you're talking, and then encourage them to talk. So use those open-ended questions, that therapeutic communication that you've talked about in other courses. But we are going to direct the focus of the conversation. So listen and observe and consider cultural differences. Remember to use silence and empathy. Some cultures that's much more important than in our culture, those moments of silence. Provide anticipatory guidance. So let them know what to expect next. If we're talking about growth and development, what are the safety things they should be thinking of that will be the next skills their child will be learning? And then if there's language, different, the family speaks a different language, consider if you're going to need a professional interpreter. You can use a family member, but that's never ideal because you don't know what words the family member does and doesn't know, what medical terms they may not understand and might interpret or translate incorrectly. Think about where you're going to have your interview with the family. Make sure there's things for the child to do so they're not interrupting, and make sure it's a comfortable setting for everyone. And then communicating with children. We need to think about the child's developmental level. We're going to talk differently to a 3-year-old than a 6-year-old, than a 10-year-old, than a 16-year-old. For children, you want to get on their eye level. It's scary when we're above them looking down. So squat down, get on their eye level. Come in slowly and fairly quietly. When you come in too fast or too loudly, the child's scared. Always be truthful. Don't tell them there will be nothing painful if something painful is going to happen. Don't tell them the painful thing's going to happen until just before it does, especially if they're young. But don't lie, because they're not going to trust you next time. And then we want to give the child choices that they have. Don't ask them if they want their medicine. That's not a choice. But what food they want is a choice. And you'll see at Children's where we really cater to them on food. Whatever they ask for, we'll call and order it. And try and use play whenever possible. A lot of your assessment you can do with play. Can they walk? Can they jump? Your whole developmental assessment is kind of fun. You're seeing what things they can do, and they think you're playing with them. So incorporate play as much as possible. And here it's a nurse down on the child's level to not be intimidating with a toy, but also talking to mom about something else. When you're talking with kids, try and avoid analogies or metaphors. You need to explain it, what they're going to experience, not some story about what somebody else did. They want to know what they're going to experience. They don't necessarily make that jump between someone else and themselves. They really are egocentric. So ask questions, but keep them simple. Give instructions, but keep them simple and clear. Use role-playing, dolls, toys, and play as much as you can. If you're giving instructions, give it in a positive manner. Try and say, go to the playroom rather than don't go to the playground outside. So try and give things in a positive manner. Avoid long sentences and avoid medical jargon. So keep things simple. Keep them words they'll understand, and think about scary words. Some of the words we're very used to sound scary to a child. When you have an older child or an adolescent, don't talk down to them. Talk at their developmental level as well, which is going to be higher than the younger child, but also realize that you need to talk to them without the parents there. If you're trying to ask an adolescent about sexual activity or drug use, you're not going to get an honest answer in front of a parent. So, developmentally appropriate communication by age. Think about infants. They're nonverbal. Their main communication is by crying, but they love looking at faces. So, the way you're going to communicate is nonverbally with expressions. Make smiling faces, make cooing sounds. Talk to them just a level above where they're currently at. So if they're doing ooh and ah, you're going to go ma 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 ma. If they're doing that, then you're going to use simple words. So in early childhood, so this is our toddlers and our preschoolers, focus on what the child's going to experience. Remember, these kids cannot put themselves in somebody else's place. They want to know what they're going to experience. Make sure you're using vocabulary they know, and then be consistent. If you're taking them into the treatment room to do a painful procedure, don't smile and laugh like it's going to be fun. But also don't look scared and worried just because you're nervous. You're going to make them worried if you're not doing something painful. So involve the parents as much as possible. If you're going to do something, let the child touch it. The blood pressure cuff, the thermometer, whatever. Obviously if it's sterile they can't touch it, but let's get one that's not the one we're going to use. That's just a demonstration, and let them touch that. And then repeat information if needed, but make sure it's simple and that we're being consistent in what we're telling them. Kids are very literal. They are imagining exactly what you say, and if you say you're going to get a little stick in your arm, they're picturing the branch coming out of their arm. If you tell them they need to take a sleeping pill, they're thinking, how funny, I wonder what pills look like when they sleep. So think about a literal interpretation, and is that really what you meant to say? So when we get to school-age kids, how do we communicate with them? Well, these kids really want information. They want to know what's going to happen, how, why. But remember, they can't think abstractly yet. So we want to be very concrete. We still want to let them touch things and practice and understand it. So touching that blood pressure cuff, or having a doll that's got the equipment that they're going to have. They also want to know that their personal possessions are not going to get lost, or people aren't going to, damage it or throw it away. So reassure them of that they can bring their personal things from home and they'll be taken care of, and still use play as much as possible. And then when we get to adolescence, these kids want us to be honest, so be sure you are being honest. They also want good detailed information. They're going to Google it, right? These guys are much more tech savvy than most of us. They're going to figure out what's going on. So be honest and give them good, accurate information. Think about privacy. Make sure things that you want that need to be asked in private, that you're making that private time for them. Because again, there's certain things you don't want to ask in front of the parents. You're not going to get a very honest answer. Adolescents, don't be surprised if they regress and act much younger at some times. They'll be very mature at some times and not at others. And these kids, their peers are very important in their life. So Being separated from the peers is a big deal for them. So ask about the peers and how to keep them connected to their peer group. History taking like you're used to with adults. We want to know the chief complaint, the history of the illness, the family history. Do certain things run in the family? But we also want to know about their usual diet. We have 100 different formulas. I'm not kidding. It's over 100 different formulas for babies at children's hospitals. So we need to know what they do take. We need to know if they're on purees or finger foods. We want to know about previous illnesses or injuries or hospitalizations. Allergies. Are they on any medications at home? We want to know about immunizations. If we know they're up to date on immunizations, there's a number of things we can rule out. We may be debating, is it this or that? But if they've been immunized, then we know it's not that one. Growth and development. We want to know what they're currently able to do. Where are they at on meeting those developmental milestones? Play. I keep saying use play as much as possible. Play is the work of the child. It's also their developmental workshop. It's how they develop those new skills and meet those developmental milestones. We can use play as a therapeutic intervention. Have them playing, showing us what they're feeling, or a way to work out their stress and their anxiety. It can be a stress reliever for their siblings as well, for the family, not just for the child. It's a great distractor for pain. Children are better at distracting themselves from pain than adults, I think. We've all had that experience of you're talking to your friend and you don't notice your headache, and as soon as you hang up the phone, you say, oh gosh, that headache I had earlier, I still have it. So we can distract ourselves from mild pain. Kids can do it up to more of a moderate level of pain. So they look like they go from no pain to terrible pain, but really it's just they're no longer able to distract themselves. It's a barometer of illness. I know with my kids I used to always say I could tell when their temperature was 102, because at 101.8 they were running around playing, and as soon as they hit 102, they'd just lay on the couch and do nothing. So when a child feels too ill to play, that's significant. When you do your physical exam on a child, we're not going to do that head to toe like we do with adults. We're going to go least invasive to most invasive, and think about where they're at developmentally. What is going to be scary for them? Make sure we don't show them equipment that's going to scare them or use words that are going to scare them. And for most kids, it's the blood pressure or the temperature that bother them the most. So if we let them save those items for last, let them touch them before we use them. Some of them have been in the hospital for a while and they're very comfortable with those things. I think the temperature, because we use a tympanic thermometer, it's where they can't see it. We're on the side of their head, coming in their ear and tugging on their ear, and they can't see what we're doing. I think that's why that one's scary, because it doesn't hurt, but it does bother a lot of children. If they're under a year, then we do an axillary temp, and babies don't like being held still, and you've got to hold that arm down. So again, that one, it's not painful, but it does bother them. And then play, involving the parents, thinking about communication, getting down on their level, using words that are appropriate. All of those things are things we want to consider in our assessment.